introduction, Tian, and thank you to the organisers for inviting me to talk and for everyone who's here to listen. So I slightly edited the title for my talk to discuss from early to long COVID, so studies that we've done in Singapore. Just some quick disclosures. I have received honorarium or speaker fees from a number of different organisations or companies, and that did include participation in a long COVID advisory programme, but not related to what's discussed here. And then just to mention that 18 months ago with colleagues at NCID, I established the long COVID clinic. So what I'm planning to talk about today is to give an overview of the structure of pandemic research. And this, I think, follows on quite nicely, actually, from what Dr. Hayakawa has been talking about, as we've followed quite a similar process in terms of using the APACC protocol for pandemic research. I'm then going to talk about how those studies that we conducted have given us some data on long COVID or long-term complications from people who've had COVID. And then finally, a bit more clinically orientated to describe the approach to long COVID that we have at the clinic in NCID. So our framework, which has evolved over the pandemic, is as described here. So the initial bit is the PROTECT study. So this is a observational clinical characterization protocol in which we enroll patients with a infectious disease, collect biological samples, collect clinical data, and then follow up for a prolonged period. What's been built onto that during the pandemic is related to PREPARE, which I'm going to skip on to next. So PREPARE is called the Programme for Research in Epidemic Preparedness and Response. It's funded by the Ministry of Health in Singapore and has a broad aim to help develop and strengthen Singapore's ability to respond to a pandemic. And so there are 5 cooperative programs, and these are the 5 main areas where funding has been placed to try to develop Singapore's ability to respond to the next pandemic. And then that's supported by clinical and research databases and supported by a long-term biorepository for any clinical samples which are collected during an outbreak. So the 2 bits which sort of connect onto PROTECT here, and which I presented in the earlier slide, is that we have, first of all, PROTECT as the observational study where we are enrolling people, obtaining informed consent for them to join the study. Then we have the PREPARE research database, which gathers data from patients who are admitted to hospital in a prospective format, but it's retrospective data, so collected by chart review and by accessing hospital databases. And then finally, as part of the first part here, the analytics of disease, that's then where we look at broader data, so going outside the hospital and connecting up and understanding the effect of an outbreak on other aspects, such as that may be Mediclaims data, so costs of healthcare. It may be vaccination programs, which are obviously not directly linked to the hospital, and any other research or academic or governmental database which is outside there. So then to move backwards, the PROTECT study. So as mentioned, this is the observational cohort study based on the APACC protocol that was established in 2012, so a good while before the COVID pandemic, as a preparation. So it was there ready for the outbreak. It was used a couple of times, both to study monkeypox when we had an imported case in 2019, and also to study the local outbreak of Zika a few years prior to that. But of course, it had never before been used in the scale at which it was over COVID-19, in which we enrolled several thousand participants, significantly less than Japan and many other countries, but for Singapore it was quite a substantial proportion. The PROTECT study covers all of the public hospitals in Singapore, so that's the 9 on the left, and then on the right are our main collaborative partners, so Duquesne US, where Prof. Lin Fa Wang is from the virologic point of view, and then we have SIDN and NTU from the immunology point of view. And of course, we work with many other people, both within Singapore and overseas. And then this was the title to the talk initially. So this was the first paper that we published in February 2020, which was examining the epidemiological features and clinical course of COVID-19, prior to it being called COVID-19, among those first 18 patients, which was published in JAMA. I just put up this chart, which I still think is very nice. So it plots out the clinical course for each participant. This was how the epidemiology unit at NCID was presenting data for all of their patients when we had just a handful around. So we were able to get a good sense of what was happening to each participant, how long they were symptomatic for before being admitted to hospital and diagnosed, whether they required oxygen or otherwise developed a severe infection, and then how long somebody appeared to be infectious for afterwards. So this gave us a nice overview. And several things were picked up very early on from this. For example, we were comparing COVID-19 very much with SARS from 2003. And we could see that the viral load trends were very different compared to SARS. With SARS, it wasn't until the second week of illness that the viral loads would peak. So I'm informed, obviously I was not around at that point. And also that the severity of illness was significantly lower than SARS. So nobody died out of these first 18 patients, and there was only a few people who developed a more severe infection. And we continued to enroll patients and to follow them up. So our subsequent paper, we call the SG100 paper. This was based on the first 100 participants who were enrolled onto the PROTECT study. And that was the first 100 out of 130 people who had been diagnosed with COVID up to that point in Singapore. And this one, we were obviously looking at the clinical features, trying to understand the proportion of people who were developing a severe illness or a critical illness. And then we were also examining what was the immune pathogenesis of COVID. So I'll just flash up some of the very well understood now inflammatory cytokine responses to SARS-CoV-2 infection. And then we were also looking at the virology. At the time in Singapore, there was a very stringent requirement for people to have a negative PCR before they could be de-isolated. And what our study helped to do and helped to show to policymakers in Singapore is that we don't need to be quite so stringent. So as the PCR viral loads drop, our ability to culture the virus also ends, and so people could be safely de-isolated earlier. We continue to follow up a proportion of these patients, and this is data after we had followed up for 1 year. We weren't specifically looking at long COVID. It was something that we were a little bit aware of very early on during the pandemic, though I had no idea what it was. I remember I followed up many of the patients that we recruited at NCID, and there was a handful who reported these unusual persistent symptoms, but did not put 2 and 2 together for a long time. And I'll come on to that again a little bit later. But what we did was we continued to collect blood samples from people coming back to clinic, and we were asking them about what symptoms they had, and observing that there were some persistent symptoms, in somewhere around 10% or so. And when we looked at finding out which people that was, at this stage it was primarily those who had a more severe infection, and that's what this logistic regression shows. So it was people who are older and who had a severe infection who are more likely to have persistent symptoms. And we've continued to follow up this group, and this was a paper we published just a couple of weeks ago, which then followed up for 2 years. It illustrates some of the problems with studies with long COVID, because we see a high number of symptoms reported, but most of them are probably not actually due to COVID anymore. And reassuringly, what we saw is those inflammatory changes, both at the cellular level and in the cytokines, by 2 years, it almost completely resolved. So moving on then from these studies to long COVID, we don't have actually a good idea of how much long COVID there is in Singapore. So there is no study which has systematically evaluated that, as far as I know. At the long COVID clinic, we see people who are referred to us with query long COVID, and we generally follow the definition from the WHO in terms of deciding whether we think this is long COVID or whether we think it's something else. The symptoms, very characteristic, and I'll just throw up the forest plot here from a meta-analysis, which I think the numbers may not be very useful in terms of the proportion of the symptoms, but it's a good overview of the frequency of them and the relative frequency of these different symptoms. As mentioned, we had seen some people who, in retrospect, I realized may have had long COVID. I thought I'd put up this, which is when we started to become aware of it from the clinical point of view. So the tweet there is supposed to be the first tweet, which uses the hashtag long COVID, which was from 21st of May 2020. And I remember reading the blog post from Paul Garner when he was describing his symptoms in the BMJ following having COVID. I think it's also true that long COVID is not new as such. However, unprepared we were for its frequency and for its persistence. So post-viral syndrome and those symptoms that people report with long COVID are described with other viral infections. We don't really know what chronic fatigue syndrome is and the various other terms that it is, which are used to describe it. And interestingly, looking back towards the 1918 influenza pandemic, no systematic studies as far as I know, but several studies have looked at long-term outcomes. And Awakenings, the film of encephalitis lethargica, the cause of that continues to be unknown and speculated, even though there was some time lag, whether it may be related to the influenza pandemic. Dengue, common in Singapore, around for a long time, but there is evidence from local studies of long dengue, so that's persistent symptoms following dengue infection. So this study here enrolled people in the GP or polyclinic when they presented with a febrile illness, and then explored which ones had dengue and then what happened with symptoms afterwards. And as can be seen from the table in the top right there, the rate of persistent symptoms was higher in those who had dengue compared with non-dengue febrile illnesses. And similar findings have been reported here from Cuba, which looked at symptoms 2 years after dengue infection. And what causes all of this? This is a paper from Eric Topol, his review of long COVID, and this covers the sort of the main hypotheses in terms of a pathophysiological mechanism behind long COVID. We believe inflammation is the main driver of this, some sort of immune dysregulation, which is why that's what we observe in our studies looking at cytokines or regulatory T cells and so on. But there are abnormalities then observed in blood clotting, the endothelium, and also in the microbiome. But these changes don't exist in isolation, and there are additional factors which then come in to determine whether somebody might actually develop that syndrome of long COVID. So social factors, psychological factors, the experiential factors, which build onto that. So the NCID post-COVID clinic, we established it in November 2021, sort of nicely timed in a way. At that point, there hadn't been that much COVID in the community in Singapore. We really saw the first big wave around about that time. And it took a few months for us to actually get the clinic going as well. So it meant when we did see the big waves of COVID in 2022 as a result of Omicron, we were a bit more prepared for it. And our aim for the clinic is that it is a hub for initial assessment. So the setting up of the clinic have partially been driven by these patients who are bouncing from specialist to specialist with no clear diagnosis, extensive investigations, and who are at their wits' end of not knowing what to do. We, of course, do not have anything fancy. We do not have any good way of diagnosing long COVID in terms of having a simple blood test or something else. It's based on our clinical judgment and based on us trying to work out does the pattern make sense? Does the onset of your symptoms coincide with your infection? And does the pattern of the symptoms fit in with what we expect from someone with long COVID? We do a number of routine blood tests just to exclude other conditions and make sure these are normal. These are the ones which are recommended by the US CDC. But really our aim is to give somebody that diagnosis if it is appropriate, and be the hub then for their care, so that when somebody comes and sees us, they're not bouncing from specialist to specialist. We're looking after them. We can then refer them onwards if necessary to rehab, cardiology, or whoever else, and then they can come back to us if those findings are normal, and then refer onwards as necessary. So somebody feels a lot less lost in the clinic. Yeah, and I just put up a summary here, which I will say I actually took from ChatGPT sometime previously, but I think it's a very good summary. Yeah, I mean, I think it does follow pretty much what we do. I'd say the only core recommendation we have probably is for vaccination, which is more of an issue when we first started the clinic, but advising people to get vaccinated if they were unvaccinated or receive their booster. Thank you very much.